Hello, good morning, sir. Sir, shall we start, sir?
Yes, Jessica, we can start.
Okay, thank you, sir. Good morning, everyone. On behalf of the Department of Anatomy of KSR Institute of Dental Science and Research, I take much pleasure in welcoming the faculties and dental as well as students from various paramedical colleges to the CD webinar on vertical integration on thyroid gland. At this juncture, I would like to appreciate our Vice Chairman, Mr. K. Srinivasan, and I cordially welcome our Principal, Sir, Dr. Sharath Ashokan, who has been great support and encouragement in organizing this CDE program. I also welcome our Vice Principals and Academic Executive, Dr. Geeta Priya, and our Administrative Executive, Dr. Prasad. I must specially thank him for his support in the technical aspects to bring this virtual event possible. I'm glad to welcome all the guest speakers of this webinar. And now may I request our Principal, Sir, to give the inaugural speech for the CD webinar titled Vertical Integration on Thyroid Gland. And the scope of this webinar is to insist the students about the importance of learning and integrating the basic medical sciences with the clinical subjects. Sir, I request you to inaugurate the webinar.
A very good morning to everyone present here. At the outset, I would like to congratulate and thank the Department of Anatomy and Jessica for organizing such an event, a vertical integration on thyroid gland. We were looking at some topic where first years and the preclinical students to have some. Am I audible? Is it clear?
Yes, sir. Yes, sir.
Okay. So we wanted some program where our first years and second years could also be benefited. And then when the anatomy department and Jessica came up with this topic, I thought it was a good vertical integration topic. And so I would like to thank all the resource faculty, Dr. Lavanya, Dr. Subhanandi, Dr. Purushothaman, and our own faculty, Dr. Tangam and Dr. Kartikesh, who are going to share their expertise on this particular topic. I'm sure all the delegates, the students, are going to benefit out of this webinar. I'd like to inaugurate this program and all the very best. Thank you.
Thank you, sir. May I now invite Dr. C. Mageshwari, Senior Lecturer in the Department of Anatomy, to introduce the first speaker of this day, Dr. Lavanya Pratap.
Good morning, all gathered here. Myself, Dr. Maheshwari, on behalf of Department of Anatomy, KSR IDSR, I'm happy to introduce our guest speaker, Dr. Lavanya Pratap, Associate Professor and HOD in charge, Savitha Dental College and Hospital, Chennai. And she was working in Gulf Medical University and was also in ACS Medical College before Savitha. And she had organized many faculty development programs, CMEs, and also many conferences and workshops. And Madam is very much interested in the field of research, and she is guiding around 5 PhD scholars now. And she has published many, 95 scientific papers in national and international journals. And also she has won many best paper awards. And she won Global Excellence Award by Global Digital Academy Mumbai in the year 2021. And she was an awarded fellow of Einstein Research Academy, Malaysia in the year 2020. And she had been as a resource person and guest speaker in many national and international CME programs, CDE as well as CPE programs. And it's my pleasure to welcome Madam as our guest speaker. Please, ma'am, I welcome you. Now over to you, ma'am, please.
Yeah, thank you. Thank you so much, ma'am. I think I'm audible. Yeah.
Yes, ma'am.
Yeah, thank you so much, ma'am, for your elaborate introduction about me. Really, I thank you. And I thank the entire organizing team, particularly Jessica, for giving me this opportunity. Really, I'm happy to be part of this team today. Shall I start the presentation, ma'am? Let me share my screen.
Yes, ma'am.
I think you have to, open the screen sharing option for me, ma'am.
I think you have to make a co-host or a host.
Yeah, the host, the display is host disabled participant screen sharing. You have to enable the screen sharing option, sir.
Ma'am, it's enabled. Just check it out, ma'am.
Yeah, sure. Yeah. Is it viewable? Yes, can you see my screen?
Yes, ma'am.
Yeah, shall I proceed?
Yes,
I think
sure,
it's audible and clear. Okay.
Yes, it's clear.
Yeah. A very good morning to one and all present here. And as I told, before I start, I wanted to thank all. And as this presentation or the discussion session is particularly focused for student, I want to thank and request all the students, my dear students and the faculty, for sparing their precious time in this. And I hope they will be gaining knowledge at the end of the session and the end of this entire event. Yeah, let me move on to my topic. This is the development and also the microstructure of the thyroid gland. And it was, even I saw the entire event schedule, it was so good that it begins with the development, proceeded to the microscopic structure, the tissue parenchyma, and then to the gross surgical, etc. It goes on. So even the flow of the topic was organized in such a good way. So let me move on to the topic. Yeah. We have our beautiful thyroid gland, which is located in the neck on either side of the trachea. The shape even is so beautiful, looks like a butterfly. One second. Yeah, sorry for the thing. It looks like a butterfly. So let me move on to the stages of development. So before I jump into directly the development of thyroid gland, let me just give a gist about the initial processes. Like soon after the fertilization, we have the initial 3-week events like the fertilized cell. It begins in the initiation of process of cell division. We call it as a cleavage. So followed by the process of cleavage, where we get 2-cell stage, 3-cell stage, 4-cell stage, the multiple cell division, it progresses. Okay, now finally, towards the end of this, we get the formation of the morula, where we get the cluster of cells. At the end of this process, towards the around the 7th day of this, we end up in the process of implantation, where the divided cell, they get embedded in the uterine wall. Followed by this, events taking place in the 2nd week, we have the conversion. I'm not talking about the entire events, just I'm going to give you a gist of that, where we the continuation of the process to the bilaminar germ disc, where we call it as epiblast and the hyperblast, which is one of the event that is happening in week 2. Followed by it, in the week 3, we have the formation or the conversion of this bilaminar germ disc to trilaminar germ disc, where you can see the ectodermal layer, the endodermal layer, and the mesodermal cells in between. So we have in future the entire body human system, we get derivatives from this 3 trilaminar germ disc, where we call this process as gastrulation. So the beautiful cleavage process which is happening in the uterine tube, followed by the process of implantation in the uterine wall, conversion of this, the cluster of cells into a bilaminar germ disc, then to the trilaminar germ disc. Okay, now what happens here is, so like this blue color, what we see here is the ectoderm, the mesodermal layer, and this yellow color is the endodermal layer. So towards the caudal end, the caudal end and the cranial end of this trilaminar germ disc, we can see the depression here. Yes, so we can see the depressions here, one towards the cranial end and one towards the caudal end. As we are talking or progressing our talk towards the development of thyroid gland, let me concentrate on the cranial end. So towards the cranial end, where you can see depression, so it's nothing but an evagination you can see here, which we call it as oropharyngeal membrane. So towards the cranial end, we have the oropharyngeal membrane, and towards the caudal end, we have the cloacal membrane. So this oropharyngeal membrane is nothing but where we can see the next stage of this is the formation of the branchial apparatus. So we can see the apparatus which is enclosing this oropharyngeal membrane. So we can see the evagination here. So when you look into detail, there is no mesoderm in between. So we have the ectoderm, which binds up with the ectodermal layer. Followed by this, we have the folding of the embryo. So the development of thyroid gland becomes the part of the formation of the alimentary tract, where we can see this. Okay, this part of it. Next, so followed by the folding of the embryo, we can see multiple linings here, which we call it as the branchial apparatus or the pharyngeal apparatus. So these are called the branchial apparatus. So which leads to the formation of all the head and neck structures. So the most prominent structure what we see here is the frontonasal process, the maxillary and the mandibular process, which are derived from the first arch. Then we have our second, third, fourth, and the sixth arch, where we have the disappearance or the rudimentary fifth arch. Okay. Now, when we take a cross section of this, when we take out this portion of the branchial apparatus or the folding of that part of the embryo, we can see this sectional appearance. So students usually they get confused, what view is this? So if we take a section, we can have this view. So the bilateral appearance of this pharyngeal arches and the pouches. So we can see the ectodermal layer, endodermal layer, and the mesodermal structure in between. Right. So before getting into the thyroid gland exactly, we need to know the gist of the tongue development as we get the proceedings of the thyroid development from it. So when you look upon this is the first arch, second arch, and the third arch. Towards the medial end of the first arch, its bilateral appearance towards the medial end, they end up in the formation of two swellings, which we call it as lingual swellings. Okay, so just below that, in between the first arch and the second arch, we have a median elevation, which is unilateral. We call it as tuberculum impar. So the two lingual swellings and the tuberculum impar, these becomes part of the development of tongue, below which we will have the hypobranchial eminence. This is nothing but this section. So what happens here? So you can see this is the first arch. Towards the medial end, you can see the two lingual swellings. Between the first arch and the second arch, we can see the median elevation called as the tuberculum impar. Now, why we are talking so about this, to talk about the thyroid gland development. We will be ending up in the formation of a proliferation of the mesodermal cells just dorsal to this tuberculum impar. Just dorsal to this tuberculum impar, we will have the elevation or the proliferation of the mesodermal cells, which we call it as, which becomes the beginning or the beginning for the formation of the thyroid gland. Hello, am I audible?
Yes, ma'am.
Yeah, okay. Okay. So this proliferation, this cellular proliferation, which we call later as foramen cecum, it descends or it results in the formation of a tubular evaginating structure, which we call it as thyroglossal.
Excuse me, ma'am. Lavanya, ma'am.
Hello.
Yes, ma'am, you are visible.
Yeah. Yes. Again, the screen sharing issue.
Okay. Please. Ma'am, it's enabled, ma'am. Kindly check.
Yeah.
You may join. Continue.
Yes, let me continue. I think there is some internet issue. So as I told, it descends down to form the bilobed mass in front of
Excuse me,
the.
ma'am.
Yes, ma'am.
From foramen cecum, if you start, it will be good, ma'am.
Yeah, okay. Yeah. So we have the two lingual swellings. We have the two lingual swellings And just below that is the median elevation called the tuberculum impar, where just behind that we have the proliferation of the mesodermal cells, remnant of which we call it as the foramen cecum. So this proliferation later it descends down or evaginates as a tubular structure, which we call it as thyroglossal duct. So this thyroglossal duct, it descends down till the upper part of the trachea, where it ends up in the formation of a bilobed structure, which later becomes the isthmus and the lateral lobes of the thyroid gland. But what structure or what component is preventing it from further descending or further growth of this thyroglossal duct is the caudal pharyngeal complex. So it's nothing but the terminal part of this pharyngeal complex, or you can tell it as a component of the fourth arch. The lateral thyroid ruminant it is. So this caudal pharyngeal complex prevents the further descending of this thyroglossal duct, and it limits at the level of the upper part of the trachea by dividing into the bilobed mass structure. Still, the contribution of the caudal pharyngeal complex is under experiment only. Later on, this thyroglossal duct, it descends in front of the hyoid bone and the laryngeal complex. Sometimes it can also just go back, or it goes back dorsal to it and come back again in ventral to the hyoid bone or in front of the laryngeal complex. In case of any disturbance in the formation or in the descending of this thyroglossal duct or its regression, we end up in getting some abnormalities. So what happens, as I told you, the surface proliferation just dorsal to this tuberculum impar, we call it as foramen cecum. This thyroglossal duct later it has to regress. It disappears. So finally, we have the bilobed structure, which is located on either side of the trachea, in the upper part of the trachea, which later becomes the isthmus and the lateral lobes of the thyroid gland. The caudal pharyngeal complex, as I told you, it helps in arresting the further descending of the thyroglossal duct. This thyroglossal duct, the entire duct, has to regress. In case of failure of regression of the entire duct, or it can take place in any of the spots, it will result in the formation of some aberrations like we call it as thyroglossal cyst. So finally, what happens to this bilobed structure? Now we have only when we talk about thyroid gland, we have two lobes on either side and the isthmus in between, which is acting as a connecting bridge between the two lobes. So this bilobed structure results in the formation of the isthmus and the lateral lobes. What is present in these two lateral lobes? It is the follicular cells, where we jump into the microscopic structure. We have the formation of the thyroid follicles. So here, this bilobed structure, it contributes in the formation of the follicular cells. So how, when we talk about that, these bilobed structure, they end up in the formation of the bilaminar cellular plates, where we have the accumulation of the colloid material in between the bilaminar plates. Later on, these bilaminar plates, they end up in formation of follicles. Follicular structure, which we call it as primordium follicles, are primary thyroid follicles. As a next step, subsequent differentiation or further budding of this primary follicles results in the formation of the secondary follicular structure. And in between this follicular structure or follicular cells, follicles, we have the parafollicular cells of the thyroid gland, which is derived from the ultimobranchial body, where we can see its structure, which is presenting just lateral to this bilobed structure. or in the branchial apparatus. So as I told you, if there is any abnormality or in any issue, disturbance in the formation of this process of development, for example, in the surface elevation or during the process of evagination or in the process of regression, it results in some congenital anomalies. So first and foremost, what we used to see frequently is the thyroglossal cyst. So it's based upon like at what region the regression is not happening, or at what region the remains of the thyroglossal cyst appears. It varies. So there are several sites. So it varies for different individuals. So these are the remnants or different sites where we can see the thyroglossal cyst appearance. Another anomaly is the lingual thyroid. So if in case the thyroglossal duct, it fails to evaginate or it fails to descend down below the level or descend down till the upper part of trachea, anywhere the bilobed, it will end up in the formation of the bilobed structure. So if in case the descending fails and the bilobed structure begins to form at the level of the lingual tissue itself, then we call it as lingual tonsil. Next, we have the intralingual thyroid. If the same process, it descends down, the thyroglossal duct, it descends down, but the bilobed structure ends up in forming within the substance of the tongue, then we call it as intralingual thyroid. Then we have suprahyoid thyroid, infrahyoid thyroid, where the bilobed structure can be formed or the descending can be stopped above the level of hyoid bone or below the level of hyoid bone. We call it a suprahyoid thyroid or infrahyoid thyroid. Retrosternal thyroid. If in case there is failure of this caudopharyngeal complex in arresting this bilobed structure at the level of upper part of the trachea, it can descend down further towards the thorax behind the sternum. Then you will have the formation of the thyroid gland behind the sternum, which is called as retrosternal thyroid. Ectopic thyroid. We would have come across the term ectopic. Ectopic is something different positions or the locations apart from its normal location. So we call it as ectopic thyroid. So its sites depend upon the abnormality in the development. We can locate this thyroid gland aggregation in any part of our neck. So we call it as ectopic position of the thyroid gland. Aberrant thyroid gland. It's like additional. Apart from the normal position of thyroid gland, we will have more in number of thyroid tissue aggregation, which we call it as aberrant thyroid. Now, what happens? As I told, we have the descending of this bilobed structure, and this bilobed structure ends in the formation of the bilaminar cellular plates within which you have the accumulation of the colloid tissue. Nothing but these cells are going to form the hormones that are expected to secrete from our thyroid gland. So when we move on in connection to the microscopic structure of the thyroid gland, the entire glandular tissue is covered by a capsule. So which is derived from the deep cervical fascia. So these connective tissue or the capsule, it sends the septa towards the tissue parenchyma or the structure of the gland, dividing into multiple lobules. You can see this white color tissue which is separating the entire lobular structure. So they are nothing but the connective tissue septas derived from the capsule. Okay, and what is this lobes? Each lobes is made up of that. I mean, previously we discussed about the bilobed structure in upper part of the trachea. That bilobed structure, which results in the formation of a bilaminar cellular plate between which there is accumulation of colloids. Later, this bilaminar cellular plate is converted to follicle. What is follicle? You can see some round shaped cells, lining cells with the space in between where the space is filled with the colloid. It's nothing but the secretion that is secreted by these cells. So this bilaminar plates, they are later converted into primary follicles. Further subsequent division and differentiation of this primary follicles results in the formation of the secondary or the definitive follicles. So this one structure, what we call a space that is encircled by the lining epithelium, is one follicular cell. So we have the aggregation of so many follicles, aggregation of follicles together again, group of follicles together again, which we divide it into lobes and the lobules of the thyroid gland. Now, what is this lining epithelium? So you can see the accumulation of the colloid structure and the lining epithelium surrounding it. What is this lining epithelium? Generally, we call it as simple cuboidal epithelium. So when in different stages, for example, when the entire follicle is filled with the hormonal, filled with colloid, the cells are in inactive stage and they are almost flat. So at this time, we call this lining epithelium as simple squamous epithelium. They become or they appear like a flattened cell. At the other end, when the cell is very active, it is in the active stage of production of its own hormone. The lining epithelium is like columnar. It looks more tall and bigger, which is in the active stage of production of its hormone. Later on, or subsequently, the other type where you have some minimal amount of colloid, it is in some resting phase or in the intermediate stage. You can see the simple cuboidal epithelium. So when the cell is completely in rest, as it is holding the entire colloid or the entire, the hormones that is secreted, we can see the flattened cellular layer, which is nothing but simple squamous epithelium. When the cells are in intermediate or the follicle is in intermediate stage of collection of colloid, we can see the appearance of simple cuboidal epithelium. At the other end, when the production of hormone is active, we can see the appearance of tall cells lining this follicles. Now, in between this follicular cells, we have the connective tissue septas. And within the connective tissue septas, we can see the parafollicular cells. So what is this parafollicular cells? These are derived from the caudopharyngeal complex, the lateral rudimentary structure forming the additional cellular structure, which we call it as parafollicular structure or C cells, which results in the production of calcitonin. So these parafollicular C cells, they can be seen, or they can be appeared in between the follicles in the connective tissue septa or in between the basement membrane and the cuboidal cells, between the cuboidal cells. So it secretes calcitonin, and the thyroid epithelium, the follicle as such, secretes the T3 and T4 hormone. So coming to the end of the session, we have the trilaminar germ disc, folding of the embryo. So at the cranial part of the pharyngeal complex, we have the first and the second pharyngeal arch. Towards the medial end of the first pharyngeal arch, we have the two lingual swellings. And just dorsal to it, we have the tuberculum impar, which lies in between the first and the second pharyngeal arch. Dorsal to the tuberculum impar, we have the appearance of surface mesodermal proliferation cells, which later becomes the foramen cecum. This proliferation ends up in the formation of an evaginating structure. We call it as thyroglossal duct. This thyroglossal duct, it descends down till the upper part of the trachea, resulting or ending up in a structure called bilobed mass. So this bilobed mass and further descending of this thyroglossal duct is prevented or arrested by the caudopharyngeal complex, which results or which contributes in the formation of the parafollicular C cells of the thyroid gland. This bilobed structure results in the formation of a bilaminar cellular plates within which the colloid substance is accumulated. Later, this bilaminar cellular plates are converted into the primary follicular cells. Further subsequent differentiation of this primary follicles results in the formation of the secondary or the definitive follicles. So where we have the accumulation of our T3 and T4 hormones. So what is the lining epithelium of these follicles? It differs at different stages of accumulation of the colloid substance. In case the cell is an active stage of production of hormone, the cells are tall columnar. In case there is an intermediate stage of some amount of accumulation of colloid, the cells we have is simple cuboidal epithelium. When the entire follicle is filled with colloid, then we have the simple squamous epithelium. The cells become flat. Further, apart from this follicular cells, we have the aggregation of group of follicles, which is forming the lobes and the lobules. Between the lobes and the lobules, we have the connective tissue septas, which are derived from the capsule of the thyroid gland. The capsule itself is derived from the deep cervical fascia. Within this connective tissue, in between the follicular cells or the lobules, we have another type of cells called the parafollicular cells, which is derived from the ultimobranchial body. So from the lateral side of this arch, you can see it migrates to the bilobed structure, which results in the formation of the C cells, contributes in the production of the calcitonin. So these parafollicular cells can be located in the connective tissue septa or in between the basement membrane of the follicular cells. So this is the entire structure. You can see the capsule, the white structure. What we see is the connective tissue septa, the parafollicular cells, the lining epithelium of the follicle, where we have the colloid filled in, which is nothing but our T3 and T4 hormone. So this is the entire cycle of the development of thyroid gland and its tissue parenchyma. Thank you.
Thank you so much, ma'am, for your great efforts in teaching our students about the embryology and histology of thyroid gland. And I'm extremely thankful to you for accepting my invitation. Let's move on to the Q&A session. If there is any questions or any clearing of doubts, we'll ask the students to post in the, we kindly ask the students to post in the question chat box of the YouTube. They will connect it. I will be
Sure.
reading that, ma'am. Ma'am, we would like to honor you with a certificate for accepting an invitation and sharing your valuable knowledge with us.
Thank you. Thanks for the opportunity. Thank you, Dr. Jessica, and the entire organizing team for giving me this opportunity. Thank you so much.
Thank you. Okay, for starting the second session, we want our principal sir to join with us. Let's kindly wait for him to join.
I'm here, Jessica.
Okay, sir. Okay. So I'll be introducing the speaker of the second session, Dr. Subba Anandi Kumarasamy, Professor in Anatomy. The guest speaker has completed her MBBS degree from Tirunelveli Medical College in the year 2000. She did her Master of Surgery in Madras Medical College. She has also completed an advanced course in medical education in 2015. She has 17 years of teaching experience and worked in various medical colleges. Currently, she is working in Indira Gandhi Medical College and Research Institute, Pondicherry. She is a member of Medical Education Unit of the same college since 2012. She is a member of Student Wellness Committee, Library Committee, and Student Mentoring Committee too. She is a life member of Anatomical Society of India, Society of Clinical Anatomists, and Association of Anatomists, Tamil Nadu. She has got 34 publications in various Indian and international journals, and her area of research interests are anthropometry and anthropology, as well as medical education. She has presented 6 papers in the state and national conferences and won Dr. M.M. Cooper Memorial Award for 2 best papers. She has been invited as a guest speaker from various medical colleges and has delivered 5 lectures. She has also given many lectures as an internal resource person in Indira Gandhi Medical College and Research Institute. Ma'am, we are very much delighted to have you today as a guest speaker on the topic gross and surgical anatomy of thyroid gland. And I would like to tell you the guest speaker of this session is the sister-in-law for beloved principal, sir. And sir, if you want to share some words about ma'am, please.
Definitely, Jessica. So I think I have to introduce her as my Annie. I think that's the best introduction I can give about her. And I think among all the guest lectures she's delivered, I think the best lectures she gives me in my life, I think are the best lectures. Over to you, Annie. I'm eager to wait to listen to you.
Thank you. Thank you, Sharad. First of all, let me thank the management of KSR Institute of Dental Sciences, the organizing team, as well as a special thank to Dr. Jessica for giving me this wonderful opportunity. Special thanks to our principal. Just 1 second. One second, I couldn't share. Is it visible, Jessica?
Yes, ma'am. Your voice is very clear and the slides are visible. You may continue.
Yeah, thank you. So this session is about the gross and surgical anatomy of thyroid gland. So the main objective of this session is to correlate the anatomy of thyroid gland with the clinical significance in relation to its parts, relations, blood supply, and lymphatic drainage. So before moving into the session, I thought I'll talk a few words about the history of thyroid gland. So the term goiter, it was in use even in around 2700 BC, but it was not documented till the Renaissance period. So the term thyroid gland is attributed to Dr. Thomas Wotton. He has mentioned about this in his book, Adenographia. And this Thyroid, it's a Greek term, thyroideus, which means a shield-like. Von Haller, it was he who classified the thyroid gland as a ductless gland. But he thought this thyroid gland was there to beautify women's neck. It lubricates the larynx, which is not so. So with this historical background, we'll move on to the anatomy part. So thyroid gland, as already said by Dr. Lavanya, this is situated in the lower part of the neck, one of the midline structure on either side of trachea. It weighs around 20 to 25 grams. It's a brownish gland. It's highly vascular endocrine gland. It's firm in consistency. So moving on to parts, we have two lateral lobes, and these two lateral lobes, they are connected by an isthmus. So this isthmus part will be present below the cricoid cartilage. So it lies against the second, third, and fourth tracheal rings. So we have two lateral lobes connected by isthmus. And in 50% of individuals, we have another lobe called as pyramidal lobe, which extends from the isthmus, usually on the left side of isthmus, and it can be connected to the hyoid bone. So what is this pyramidal lobe? Is nothing the persistence of Thyroglossal duct, the distal part of Thyroglossal duct. Usually it disappears, but in 50% of individuals, the distal part of the Thyroglossal duct can persist as pyramidal lobe. So it's a normal part. This thyroid gland extends from the fifth cervical vertebra up to the first thoracic vertebra. So like any gland, it's covered by a capsule. So the condensation of fibrous tissue, we call it as true capsule. From the true capsule, we have septa entering inside the gland. And we have venous plexus lying beneath the true capsule. Outside the true capsule or external to the true capsule, we have the false capsule, which is the pre-tracheal fascia. So pre-tracheal fascia is one of the deep fascia of neck. We have three deep fascia layer. The anterior layer is the investing layer of deep cervical fascia. The middle layer is the pre-tracheal layer, and the deep layer or the posterior layer will be the prevertebral layer. So this middle layer, the pre-tracheal layer, encloses the thyroid gland, forms the false capsule of thyroid gland. It ascends upwards, and when you trace it upwards, it gets attached to the oblique line of thyroid cartilage. So this is the oblique, here will be the oblique line of thyroid cartilage. So it gets attached to the oblique line of thyroid cartilage. You trace it upwards, it goes up to the hyoid bone. So upper attachment of pretracheal fascia here is to the hyoid bone. Same way, when you trace it downwards, it enters into the thorax and it fuses with the fibrous pericardium. So this is a vertical extent of pretracheal fascia. So this false capsule is also called as surgical capsule, and it is also called as perithyroid sheath. So if you look at the clinical aspect of the capsule, as I've already told you, this is the true capsule. Beneath the true capsule lies the venous plexus. So you have the venous plexus, then outer to it lies the true capsule. So when they remove the thyroid gland in thyroidectomy, this true capsule is removed along with the gland. External to it lies the false capsule. Between these two, you have a small space which is occupied by the parathyroid glands. So we have a pair of superior parathyroid gland and a pair of inferior parathyroid gland. So these parathyroid glands are present in the space between the true and false capsule. this false capsule is not removed during thyroidectomy. So remember this. This false capsule is kept. It is not removed during thyroidectomy. So during thyroidectomy, the true capsule is removed along with the gland. The same false capsule, which is formed by the pre-tracheal fascia, when you trace it horizontally, this gets condensed medially and gets attached to the cricoid cartilage. So it's one of the laryngeal cartilage. So here you can see here, it gets attached to the cricoid cartilage. And you can see a nerve very close related to the suspensory ligament of Berry. This condensation is called as ligament of Berry, named after Sir James Berry. He was a British surgeon. So this medial condensation of pretracheal fascia is called as suspensory ligament of thyroid or suspensory ligament of Berry. So during thyroidectomy, again, we have to release this suspensory ligament of Berry. So before cutting this suspensory ligament of Berry, care should be taken not to injure the recurrent laryngeal nerve. So the recurrent laryngeal nerve lies in the tracheoesophageal groove. That is, there is a groove between the trachea in front and esophagus behind. In this tracheoesophageal groove lies the recurrent laryngeal nerve. So this recurrent laryngeal nerve can sometimes pierce the suspensory ligament of Berry, or usually it lies behind it. Sometimes it can lie anterior to it. So care should be taken not to injure the recurrent laryngeal nerve. Because of these attachments of the thyroid gland to the laryngeal cartilages through suspensory ligament of Berry, it is attached to the, through the suspensory of ligament of Berry, it is attached to the cricoid cartilage. Through the pretracheal fascia, when you trace it upwards, it's attached to the thyroid cartilage as well as to the hyoid bone. So when you ask the patient to swallow, this thyroid swelling moves up during deglutition. So that's how to confirm a thyroid swelling. So you ask the patient to swallow, this swelling will move up and down during deglutition. So this confirms the swelling is from the thyroid gland. Now moving on to the parts of a thyroid gland. Already we have seen that it has two lateral lobes. So easy to study, have a pinched fingers. The fingers should face upwards. So in thyroid gland, in the lateral lobe, apex will be facing upwards. The base is down. Just opposite for the parotid gland. For parotid, apex will be facing downwards and the base will be upwards. So when you study thyroid gland, have the pinched fingers so that you know apex is facing upwards. So apex is sandwiched between two muscles. One muscle is a strap muscle, that is a sternothyroid muscle. So sternothyroid muscle gets attached to the oblique line of thyroid cartilage. It's stripped here. So this is a sternothyroid muscle. And you have one another muscle here, that is the inferior constrictor. So it is between these two. Because of this attachment of sternothyroid to the oblique line of thyroid cartilage, this apex part cannot enlarge beyond this attachment. So enlargement of thyroid gland to upside, that is upwards, is limited by the attachment of sternothyroid to the oblique line of thyroid cartilage. In addition to this, apex is related to three structures. The important artery, that is a superior thyroid artery, which is a branch of external carotid artery. This artery, accompanied by superior thyroid vein, is also related to the apex. So this vessel, superior thyroid vessel, is accompanied by a nerve. This nerve is called as external laryngeal nerve. So vagus, which is the 10th cranial nerve, gives a branch in the neck called a superior laryngeal nerve. This superior laryngeal divides into two, an external laryngeal and an internal laryngeal. As name implies, the external is outside the larynx, external laryngeal, and this nerve supplies cricothyroid muscle. It's a pure motor nerve. It supplies this muscle, only this muscle, cricothyroid. And the internal laryngeal nerve, as name implies, it is internal. It pierces the thyroid membrane, enters the larynx. It's a pure sensory nerve, supplies the larynx up to the vocal cord. So area above the vocal cord is supplied by internal laryngeal nerve. So remember, three structures are related to the apex: superior thyroid artery, superior thyroid vein, and external laryngeal nerve. Moving on to base. Base is related to two structures. We have inferior thyroid artery. This inferior thyroid artery is a branch of thyrocervical trunk, which in turn is a branch of subclavian artery. So this is not accompanied by a vein. Inferior thyroid vein does not accompany the inferior thyroid artery. So we have only the inferior thyroid artery. But here, the nerve here is the recurrent laryngeal nerve. So already you have come across this recurrent laryngeal nerve while releasing the ligament of Berry. So this recurrent laryngeal nerve is also a branch of vagus nerve. This nerve is a mixed nerve. So it gives sensory branch as well as motor branch. So this branch, that is a recurrent laryngeal nerve, supplies all the muscles of larynx except cricothyroid, which is supplied by external laryngeal nerve. This is also a sensory nerve below the vocal cord. So supraglottic part is supplied by internal laryngeal nerve, whereas the infraglottic part, that is the area below the glottis, that is below the vocal cord, is supplied by recurrent laryngeal nerve. So this has to enter inside the larynx. So how it enters is, you have a joint between cricoid and thyroid, that is a cricothyroid joint, that is closely related to this ligament of Berry. Behind it, it pierces and enters the larynx. So this base of thyroid gland, it can descend up to the 6th tracheal ring. And base is related to inferior thyroid artery and recurrent laryngeal nerve, important nerve. Moving on to the surfaces. Surfaces, since you studied with the pinched fingers, the space between the thumb and the little finger, consider it as medial surface. Suppose you have your right finger. So space between the thumb and the little finger comes as your medial surface of right lateral lobe. This becomes the superficial surface, which is also called as anterolateral surface. The space between the thumb and the index finger comes as the posterolateral surface. So we have an anterolateral surface, otherwise called as superficial surface. In some of the textbooks, it will be given as superficial surface alone. You have anterolateral or superficial. We have posterolateral surface and an important surface, medial surface. Now this little finger will come as an anterior border. So this anterior border separates the medial surface from the superficial surface, otherwise anterolateral. This thumb, consider it as a posterior border. So this posterior border separates the medial surface from the posterolateral surface. Okay, so we have two borders, anterior border, posterior border. We have three surfaces, a medial surface, superficial surface or anterolateral, and posterolateral surface. Now, if you look at this anterolateral surface, so this is overlapped by the strap muscles. We have sternothyroid, sternohyoid, superior belly of omohyoid. So these strap muscles are supplied by the ansa cervicalis. And all this external to this strap muscles, we have an important muscle that is a sternocleidomastoid muscle. So these are the muscles which is related to the anterolateral surface. Superficial, if you want to go still more superficially, we have the investing layer of deep cervical fascia. Then you have the skin, platysma and skin. So anterolateral surface is related to the muscles. Moving on to the posterolateral surface. Posterolateral surface is related to important content here, that is the carotid sheath with its contents. So as you all know that common carotid artery, as well as the internal, when you trace it upwards, is covered by a sheath, the carotid sheath. Lateral to the common carotid artery, we have internal jugular vein. Between these two vessels, that is the artery medial and the vein lateral, somewhat posteriorly lies the vagus nerve. So we have three structures enclosed by the carotid sheath, and this carotid sheath is related to the posterolateral surface. The posterior border is related to the descending branch of superior thyroid artery, which is anastomosing with the ascending branch of inferior thyroid artery, as well as we have the parathyroid glands. Important structure, the parathyroid gland is related to the posterior border. Anterior border, we have the anterior descending branch of superior thyroid artery. So we have an important surface, the medial surface. It's easy to study, already you have studied. Two tubes related, that is a trachea and esophagus. So we have trachea in front and esophagus behind. So two cartilages, it is related. We have the cricoid cartilage, we have the thyroid cartilage. We have two muscles related. So definitely these two muscles should be related to this cartilage. We have the cricothyroid cartilage muscle, and this cricothyroid muscle is supplied by external laryngeal nerve. We have the inferior constrictor of pharynx, which is attached to this both the cartilages, thyroid and cricoid. So two muscles, cricothyroid muscle and inferior constrictor of pharynx, it's related to the medial surface. And of course, the two nerves, the external laryngeal nerve and recurrent laryngeal nerve, which lies in the groove between the trachea and esophagus. So all these structures are related to the medial surface of thyroid gland. So if you look at the applied aspect in relation to the medial surface, whenever there is an enlargement, abnormal enlargement of thyroid gland, and especially in malignancy of thyroid gland, we have pressure effects over these structures. So when it compresses the trachea, patient can present with difficulty in breathing, shortness of breath, we call it as dyspnea. When it compresses the esophagus, patient may complain of difficulty in swallowing, which we call it as dysphagia. When it compresses the important nerve, the recurrent laryngeal nerve, patient will complain of hoarseness of voice. Since these structures are related to the medial surface of the gland. So coming to the connecting part that stretches between the two lateral lobes. So this is the isthmus. So to study isthmus, have your hand in this position, horizontal. So you have this border is the upper border or superior border, that is along your index finger. Along your little finger, that comes your lower border. So this is your upper border, otherwise superior border, and this comes as inferior border or lower border. And this dorsum of hand comes as your anterior surface, and the palmar aspect comes as your posterior surface. That is a surface which faces you. So you have two surfaces and two borders, a superior border or upper border, inferior border or lower border, an anterior surface and a posterior surface. Anterior surface can be called as a superficial surface and a posterior surface can be called as deep surface. So now to this superior border, you can see here the superior thyroid artery as it approaches the apex divides into an anterior branch and a posterior branch. So anterior branch descends along the anterior border of the thyroid gland, comes to the superior border of thyroid gland, and here it anastomoses with the anterior branch of the other side of the superior thyroid artery. This right side will anastomose with the opposite or the left side superior thyroid artery. So they both will anastomose along the upper border or superior border of isthmus. We have already seen sometimes in 50% of individuals, there can be a pyramidal lobe which can be attached to the superior border of isthmus. Coming to the inferior border, we have the inferior thyroid veins emerging out. So it is related to the inferior thyroid. There is an inferior border related to the inferior thyroid vein. Inferior border is also related to an artery called as thyroidea ima artery. So thyroidea ima artery is an unpaired artery, a single artery. This artery, if it is present only in 3% of individuals. If it is present, it will be related to the inferior border of isthmus. So care should be taken. Again, this is for tracheostomy. When they go for an emergency tracheostomy, care should be taken not to injure the inferior thyroid vessels, that is a vein, as well as they have to look for an accessory thyroid artery, that is thyroidea ima artery. So this vascular relation is important before doing tracheostomy. Coming to the surfaces, anterior surface or superficial surface. When you go from superficial, we have skin, we have the platysma, we have the investing layer of deep cervical fascia. We have a vein here, that is the anterior jugular vein. So these structures, then of course this pre-tracheal fascia, all this. So we have the anterior jugular vein, the strap muscles, the same strap muscles, sternohyoid, sternothyroid, they all form the anterior relation to this isthmus. Posteriorly, it is related to the second, third, and fourth tracheal rings. Coming to the applied aspects, there can be agenesis of isthmus or partial agenesis, which we call it as hemiagenesis of isthmus. So here it is a agenesis of isthmus. There is complete disappearance of isthmus. So this is a case where you can see only the two lateral lobes and there is no isthmus. Directly you can visualize the trachea. So moving on to the blood supply. Blood supply includes arterial and venous drainage. As I have already told you, it's a highly vascular endocrine gland. So this is supplied by superior thyroid artery, supplied by inferior thyroid artery. In 3% of individuals, we have thyroid ima artery. Ima means single or unpaired. So this thyroidea ima artery, if it is present, it can arise from the brachiocephalic trunk or it can directly arise from the arch of aorta. Apart from these arteries, we have arteries arising from the trachea, that is branches to the trachea, from the esophageal branches also. So we'll see in detail about the superior thyroid artery. Superior thyroid artery is a direct branch arising from the external carotid artery. So external carotid artery, that is, it arises from the common carotid artery at the level of upper border of thyroid cartilage or disc between C3 and C4. The common carotid artery terminates into external and internal. The first branch of external carotid will be the ascending pharyngeal. It's a medial branch. So the second branch is the superior thyroid artery. We have anterior branches. Among the anterior branches, the superior thyroid artery is the first branch. So first anterior branch, and it is not the first branch of external carotid artery. First branch will be ascending pharyngeal. Okay. Among the anterior branches of external carotid artery, superior thyroid artery is the first branch. So external carotid artery gives the superior thyroid artery. So as the superior thyroid artery descends, it gives superior laryngeal artery, which accompanies the internal laryngeal nerve, pierces the thyroid membrane, enters the larynx. It gives sternomastoid branches to the sternocleidomastoid. Sternocleidomastoid, again, it is highly vascular. So it gives sternomastoid branches to the sternocleidomastoid muscle. Then it descends downwards. It approaches the apex of the thyroid gland. So till here, you can see a nerve accompanying it. This nerve here at its origin, it is a superior laryngeal nerve. Then it has divided into internal and external. Internal has entered inside the larynx. Now it is the external laryngeal nerve, which is accompanying the superior thyroid artery. So as it approaches the apex of the thyroid gland, it splits into two branches. The anterior branch of superior thyroid artery descends along the anterior border of the thyroid gland, comes to the superior border of isthmus of thyroid gland, anastomose with the opposite branch. The posterior descending branch of superior thyroid artery descends along the posterior border of thyroid gland, and here it anastomoses with the ascending branch of inferior thyroid artery. So what you have to remember here is, in the upper part, you have a nerve accompanying it, that is the external laryngeal nerve. So external laryngeal nerve will supply the cricothyroid muscle. Okay. So here you can see a muscle stretching between the cricoid cartilage and the thyroid cartilage, that is called as cricothyroid muscle. And this is the only laryngeal muscle situated outside. So this muscle is supplied by this external laryngeal nerve. This nerve, when you trace upwards, here it is closely related. But as it approaches the superior thyroid, as it approaches the apex, this external laryngeal nerve diverges from this artery. The superior thyroid artery alone will be accompanied by superior thyroid vein. The other thyroid veins will not accompany the corresponding arteries. So here it will be accompanied by the vein also. So remember, whenever you study the superior thyroid artery, the nerve accompanying is the external laryngeal nerve. So coming to the clinical aspects, during thyroidectomy, these vessels should be ligated, should be tied and ligated. So where to tie this superior thyroid artery is as much close to this apex, because closer to the apex, you can see the external laryngeal nerve is diverging. So here you will tie only the artery and the nerve will not be included in the ligature. So this superior thyroid artery is ligated close to the apex of the thyroid gland to avoid injury to this external laryngeal nerve. External laryngeal nerve, if at all is injured in thyroidectomy, it goes unnoticed except in singers. So this is for high pitch voice. So in singers, external laryngeal nerve injury can be seen. It can be noticed. Otherwise, it goes unnoticed. So coming to the second branch, that is the inferior thyroid artery. So inferior thyroid artery is a branch arising from the thyrocervical trunk. So you can see here, this is the thyrocervical trunk, which arises from the subclavian artery. The first part of subclavian artery gives us thyrocervical. Thyrocervical gives this inferior thyroid artery. This view is the posterior aspect. You are viewing the thyroid gland from behind. So what you have here is the common carotid artery. So this inferior thyroid artery passes behind the carotid sheath. It pierces the pre-tracheal fascia. Till now, it has not given any branches. As it approaches the base of the thyroid gland, after piercing the pre-tracheal fascia only, it gives branches. It divides into 2 or 3 twigs. The first branch is called as inferior laryngeal artery, which accompanies the external, that is recurrent laryngeal nerve. This also enters inside the larynx, supplies the area below the vocal cord. so inferior laryngeal artery. The other branches, they supply the parathyroid gland. So parathyroid glands, the inferior parathyroid gland is always supplied by branches from the inferior thyroid artery. Superior parathyroid gland, 90% of individuals, it is supplied by inferior thyroid artery. But in 10% of cases, it can be supplied by an anastomotic branch. That is the anastomosis between the ascending branch of inferior thyroid artery and the posterior descending branch of superior thyroid artery. So this superior thyroid descending branch can supply in addition to the inferior thyroid artery. So that is only a minimal, that is only in 10% of individuals. So remember, these parathyroid glands are supplied by branches arising from the inferior thyroid artery. So the nerve accompanying this inferior thyroid artery, what you see here is a recurrent laryngeal nerve. So the older concept in tracheostomy while ligating the inferior thyroid artery is, they say to avoid injury to the recurrent laryngeal nerve, it's better to ligate the artery away from the gland. We say away from the base. It's an older concept. The newer concept is, according to surgeon's view and even in Gray's and some of the latest textbooks, it's changed. It's better to ligate this artery, the inferior thyroid artery, close to the base because the blood supply to the superior and the inferior parathyroid should not be compromised. If it is lost, it leads to hypoparathyroidism. Patient presents with tetany. So it's always ligate the inferior thyroid artery close to the base of the gland. Before ligating the artery, look for the recurrent laryngeal nerve, preserve the recurrent laryngeal nerve, then ligate the artery close to the base of the gland. That's the newer concept. If at all the recurrent laryngeal nerve is injured during thyroidectomy, in unilateral injury, the vocal cord along the paralyzed side can lie in a paramedian position. The patient can present with the hoarseness of voice. Voice doesn't change much in a unilateral injury. But if it is a bilateral, definitely patient presents with the hoarseness of voice. And depending upon the position of the vocal cord, if it is in a paramedian position, airway obstruction doesn't occur. But if it is in an adducted position, both the vocal cords in an adducted position in recurrent laryngeal nerve injury, that is bilateral recurrent laryngeal nerve injury, the patient presents with airway obstruction, which needs emergency tracheostomy. So we'll have a small question and answer. A 40-year-old woman with goiter comes to the hospital for surgical treatment. The surgeon ligates the superior thyroid artery before resecting the goiter. So care must be taken to avoid injury to which of the following nerves? A, internal laryngeal nerve, B, recurrent laryngeal nerve, C, external laryngeal nerve, and D, superior laryngeal nerve. Students, you can message in the chat box. So when you ligate the superior thyroid artery, to avoid injury to the nerve involved or the nerve accompanied the superior thyroid artery. So which nerve is injured? So which nerve is related to the superior thyroid artery? Any answers, Dr. Jessica?
No, ma'am.
Okay, then I'll move on. It's the external laryngeal now. Okay. So in the above case, if the external laryngeal nerve is damaged during the surgery, it could result in severe impairment of which of the following? Relaxing the vocal cords, tensing the vocal cords, abducting the vocal cords, widening the remoglottis. So the cricothyroid muscle is supplied by the external laryngeal nerve. The cricothyroid, on contracting, it pulls the thyroid cartilage forwards. As a result, the vocal cord will be tensed. So tension of vocal cord. Right. We'll move on to the venous drainage. So we have 3 sets of veins. The one superior thyroid vein accompanies the superior thyroid artery. Remember, the plexus, venous plexus, is related beneath the true capsule. So from here, it arises as 6 pedicles here, 3 on the right and 3 on the left. So the upper pedicle here emerges as the superior thyroid vein, emerges from the apex of the thyroid gland, accompanies the superior thyroid artery, and it drains into the internal jugular vein. We don't have any middle thyroid artery, but we do have middle thyroid vein. So middle thyroid vein emerges along the lateral surface of the thyroid gland, and it drains into the internal jugular vein. We have inferior thyroid vein, which we have already seen. This inferior thyroid vein is related to the isthmus, lower border of isthmus of thyroid gland. So from here, it can arise as 2 trunks. It can open into the corresponding brachiocephalic vein, the right and left. But usually what happens is they both join together. They form a single inferior thyroid vein, and they usually drain into the left brachiocephalic vein. Okay. So remember, superior thyroid vein and middle thyroid vein drains into internal jugular vein, whereas inferior thyroid vein drains into the left brachiocephalic vein. We have the 4th vein, which is called as Cocker's vein, named after a Swiss surgeon, that is Emil Theodor Cocker, and he was awarded Nobel Prize in 1909. So it is named after Theodor Cocker. The 4th vein usually present below the inferior thyroid vein, and if this Cocker's vein is present, it will open into or drain into internal jugular vein. Moving on to lymphatic drainage. For our convenience, we divide it into a medial part and lateral part. Similarly, upper half and lower. So here medially in this upper part, this opens into the prelaryngeal lymph nodes. The lower part opens into the or drains into the pre-tracheal lymph nodes. From here, it drains into the paratracheal lymph nodes. And in the lateral part, upper part of lateral half, there is a lateral lobe that drains into the upper deep cervical lymph nodes. It goes to these lymph nodes, they lie along the course of the internal jugular vein. So they go to the jugulodigastric lymph nodes, and lower half, they drain into the lower deep cervical lymph nodes. So especially you have the jugulo-omohyoid lymph node. So this is a lymphatic drainage. The pre-tracheal lymph node is also called as Delphian lymph node. Coming to another anomaly here, a common anomaly, there is Levator glandulae thyroidae. It's a muscular tissue. So this muscular tissue can extend from the apex of the thyroid lobe. There is a pyramidal lobe to the hyoid. If the pyramidal lobe is present, this Levator glandulae thyroidae can extend from the apex of pyramidal lobe to the hyoid, or when there is no pyramidal lobe, it can directly extend up to the isthmus. So if the Levator glandulae thyroidae is present, depending upon the position, if it is present medially, it is supplied by the nerve which supplies the cricothyroid. So the nerve that supplies the cricothyroid is the external laryngeal nerve. So if it is present medially, the external laryngeal nerve supplies this levator glandulae thyroidae. If it is present somewhat laterally, this is the levator glandulae thyroidae. So if it is present somewhat laterally, it is supplied by the ansa cervicalis, which supplies the strap muscles. Ectopic thyroid tissue was already discussed by Dr. Lavanya. So it can be present along the pathway of the descent of Thyroglossal duct. It can be present near the trachea, near the esophagus. It can be present near the foramen cecum also. So what you see here is, this is a video. What you see here is a vocal cord. Okay, so you can see the vocal cord. This is the epiglottis, and you see a swelling here. Again, a vascular swelling. So this is inside. You can see the movements of vocal cord. That was a soft palate, uvula. So this swelling is a lingual thyroid. So lingual thyroid, that is when the descent of thyroglossal duct is arrested. When it fails to descend, the thyroid gland will be present in the foramen cecum, and it is called as lingual thyroid. Usually they don't go for thyroidectomy unless patient presents with complications like airway obstruction. And before going for thyroidectomy, they have to look whether there is an accessory thyroid tissue present. So abnormal enlargement of thyroid gland is called as goiter. Goiter can be due to hypothyroidism, it can be due to hyperthyroidism, or it can be due to euthyroid also. Retrosternal goiter, from the base of the lateral lobe, there can be some enlargement, and this enlarged thyroid gland can extend into the thoracic cavity. It extends usually into the mediastinum, anterior mediastinum. So it can compress the trachea. So patient can present with dyspnea. It can compress the blood vessels. So there'll be flushing in the face. So this is extension of part of thyroid tissue into the thoracic cavity. So for malignancy, the surgeons, they opt for thyroidectomy. So depending upon the type and the stages, they remove the part of the thyroid gland. So when one lobe is removed, they call it as thyroid lobectomy. So when they remove one lobe along with the isthmus, leaving only small part of the lateral lobe, then they call it a subtotal thyroidectomy. So total thyroidectomy is removal of the two lateral lobes along with the isthmus. So sometimes isthmus alone can be removed, which we call it as isthmusectomy. Okay. So this is to show the cancer awareness ribbons. Here we have the thyroid carcinoma ribbon. You have it's tricolor. We have pink, blue, and teal. Suppose they go for a thyroidectomy. So what are the possible complications? First is it's a highly vascular endocrine gland. So you expect hemorrhage. Okay, it bleeds profusely. It's supplied by so many vessels. Second common complication is recurrent laryngeal nerve injury. So what they do is, before ligating the inferior thyroid artery, look for the recurrent laryngeal nerve, preserve it, then ligate the vessel. Third common complication is hypoparathyroidism. Parathyroid gland should not be removed with the thyroid gland. So the artery to the parathyroid gland, that is the inferior thyroid artery, should not be ligated. Okay, this artery, that is a blood supply to the parathyroid, should be preserved. After giving the vessel to the parathyroid, then the distal part of the inferior thyroid artery should be ligated. So inferior thyroid artery should be ligated close to the base of thyroid gland to avoid injury to this vessel supplying the parathyroid. If it is injured, it can lead to hypoparathyroidism. Patient can present with symptoms of tetany. Suppose during thyroidectomy, they remove this parathyroid gland. What they do is they re-implant it in the sternocleidomastoid muscle. So within the sternocleidomastoid muscle, they re-implant it. As I've already told you, sternocleidomastoid is also highly vascular. So that will take care of its blood supply. So it should be re-implanted back into the sternocleidomastoid muscle. When they go for total thyroidectomy, it leads to hypothyroidism. Least complication is the external laryngeal nerve injury, which accompanies the superior thyroid artery. External laryngeal nerve supplies the cricothyroid, the one limb, one muscle, and it's a tensor of vocal cord. So patient will not present any complaint unless she or he is a singer. So that hitting high pitch is not possible if external laryngeal nerve is injured. So to summarize, I always stress, remember, thyroid gland is a highly vascular endocrine gland. So important arteries, superior thyroid artery, a branch of external carotid artery, is accompanied by superior thyroid vein and the nerve accompanying. Study it as a boy, the nerve accompanying is the external laryngeal nerve. So inferior thyroid artery, the boy accompanying this inferior thyroid artery girl is the recurrent laryngeal nerve. So to avoid injury to the external laryngeal nerve, superior thyroid artery is ligated close to the apex of the thyroid gland. To avoid injury to the recurrent laryngeal nerve, the artery, to avoid injury to the blood supply to the parathyroid, the inferior thyroid artery is ligated close to the base of the thyroid gland. That's the newer concept. So moving on to the questions. Is it possible, or we'll move on, Dr. Jessica?
Yes, ma'am. Yes, ma'am. We'll ask them to.
Okay. The suspensory ligament of thyroid gland is a derivative of investing layer of deep cervical fascia, pre-tracheal layer of deep cervical fascia, the pre-vertebral layer of deep cervical fascia, or option D, thyrohyoid membrane. See, try, just give a try. It's okay if you answer wrong also, we can discuss here.
I request the students to post their answers in the chat box.
Any answers, Dr. Jessica? No?
Ma'am.
Okay, then we'll move on.
Most of them have answered, ma'am.
Okay.
External laryngeal nerve and tensing the vocal cords. It's
Oh,
deliberate.
thank you.
But now maybe it's taking time. I think.
Okay, then I'll wait.
Okay, ma'am.
Shall I wait or we'll move on?
We have got the answer. One person, Achi Anbu, investing layer of deep cervical fascia.
Okay, that's not the correct answer.
Madhumita Bhupati, pre-tracheal layer.
Yeah, that's the correct answer, and congratulations. So suspensory ligament of Berry, it's the false capsule thickening. So thickening of false capsule along the medial aspect. So that is a pre-tracheal layer. Pre-tracheal layer forms the false capsule. Okay. So this part, suspensory ligament of Berry or posterior ligament of thyroid, this gets attached to the cricoid cartilage. The next question is, thyroid venous plexus lies. Option A, beneath the true capsule. Option B, external to the true capsule. Option C, beneath the true and false capsule. And option D, beneath the false capsule.
Ma'am, from one person, Navina M, student, she has answered beneath the true capsule.
Yeah, very good. Very good, ma'am. So thyroid venous plexus lies beneath the true capsule. So what structure lies between the true and false capsule is the parathyroid gland. So parathyroid gland lies between the true and false capsule. Even the arterial pedicles lies between the space between the true and false capsule. Good.
Most of the students have answered beneath the true capsule.
Oh, thank you, ma'am. Very good. Now, the fifth question is, inferior thyroid artery is a branch of option A, external carotid artery, option B, internal carotid artery, option C, thyrocervical artery, and option D, arch of aorta.
Madhumita Bhupati, Navina, Asmita Raj, and Subraja, Navina M have answered as thyrocervical trunk.
Yeah, very good. Very good, Mark. Congratulations. So here, the thyrocervical artery is a branch of subclavian artery. Okay, so external carotid artery gives the superior thyroid artery. Internal carotid artery doesn't give any branch in the neck. From arch of aorta, if there is a thyroidema artery, usually it arises from the arch of aorta or from brachiocephalic trunk. Good. So moving on to the sixth question, which of the following veins drains into the brachiocephalic vein? Option A, superior thyroid vein. Option B, inferior thyroid vein. Option C, middle thyroid vein. And option D, Cocker's vein, the fourth vein of thyroid gland, that is the Cocker's vein.
Madhumita Bhupati, Navina have answered as inferior thyroid vein.
Very good, very good.
Most of the students have answered.
Yeah, very good. So it's the inferior thyroid vein which drains into the brachiocephalic vein. All the other veins, that is a superior thyroid vein, middle thyroid vein, and the fourth vein, the Cocker's vein, they drain into the internal jugular vein. So this is a reference. On behalf of the organizing team, as well as from my side, I request Dr. Sharath Ashogan to give chocolates to the students. There is at least the first 3 students who have answered. Yeah, thank you. Hope you have enjoyed the session. Thank you. And once again, I thank Dr. Jessica for giving me this wonderful opportunity. Thank you, Jessica. Any questions?
Students, you may post your questions in the chat box. Ma'am, I would like to thank you very much for accepting my invitation first. You are a very senior person. When I called you and invited you, just
it's my pleasure.
Thank you so much. You are a very humble person. We are very lucky to have your lecture, hear your lecture actually, and we learned many things from your lectures, ma'am. How to express each and every terminology of anatomy to the students, so that they may, when they hear it itself, they know which and all will be important. So thank you very much, ma'am, for your elaborate lecture and very clearly taken.
Thanks, Dr. Jessica. It's my pleasure.
We would like to honor you with a certificate.
Yeah, thank you. Thank you, Jessica. Thank you. Thank you.
Okay, என்ன மேம் பார்ட்டிசிபென்ட்ஸ்ல காணுமே மேம்
Purushottam sir.
Yes, madam. I'm audible, madam.
Sir, I cannot find your name in the Zoom link, please.
Yes, this one, madam.
Okay, it's Physiology. Now you have made us a co-host, sir.
Okay.
I'd like to invite Mrs. Sharanya, Senior Lecturer in the Department of Anatomy, to give introduction to the guest speaker of this hour.
Good morning, sir. I am happy to introduce Dr. Purushottam sir. He did PG in University of Madras, Chennai, and he did PhD in Mahad University, Chennai. He has 13 years of teaching experience in various institutions. He has published many research papers in indexed journals. He has done many original research projects, and currently he is working in Vivekananda Dental College for Women as a reader, Department of Physiology. Happy to introduce sir. Please welcome sir for the session.
Thank you, madam. I'm audible now.
Yes, sir.
Yeah. First of all, I would like to thank Dr. Mahilan sir and the management of KSR Dental College for giving me the opportunity to present the topic. Today, I'm going to present the topic on thyroid hormone synthesis, secretion, function, and its regulations. Okay, these topics covered under the outline of physiology of thyroid gland and thyroid hormone synthesis and secretions and T3, T4, thyroid hormone and functions of thyroid hormone and regulations of thyroid hormone secretions. As we know, this thyroid gland is situated on either side of the hypothalamus. It has two lobes, left and right lobe, that are connected between in the middle by the isthmus. It receives a maximum blood supply. It weighs about 20 to 40 gram in adults. So it will receive around 80 to 250 ml per minute. Now we'll see histological organization of thyroid gland. See, this thyroid gland, the structural and functional unit of thyroid gland is your follicular cells. These follicular cells secretes more thyroid hormones. These thyroid hormones are stored in inside the follicles, that is called as colloid. Whenever there is a requirement of thyroid hormone from the colloid, it releases into the circulations. Now, these follicular cells generates the thyroid hormones, and in addition, there is a parafollicular cells that is present nearer to your follicular cells. It secretes calcitonin. The main role of calcitonin is to regulate the calcium ion, okay, in our body, and it also helps to lowering the calcium level in our body. Okay, there's some summary. Follicular cells that produce a thyroid hormone T3 and T4, and in colloid, it consists of a large glycoprotein. It's called as thyroglobulin, and parafollicular cells is also called as C cells. It secretes calcitonin. It will be lowering your calcium level and also regulating the calcium in our body.
Okay, thank you, sir.
Now we'll see in detail about the biosynthesis of your thyroid hormone. First, a follicular cell synthesizes an enzyme and thyroid globulin for colloid. Iodine travel into the blood, iodine trapping by the follicular cells with the sodium co-transport mechanism. Synthesis of thyroid hormone by adding your iodine and an enzyme, where it will occur oxidation of iodide that back to your iodine. Ionization and organic exchange also occurs. Coupling and condensation reaction will occur, and finally the thyroglobulin will be stored in the colloid. Whenever there is a requirement in our body, it releases thyroid hormone T3 and T4, and finally it will be entering into your blood circulations. Now we'll see one by one in detail. Now, the iodine. Iodine is a main factor for the generation of your thyroid hormone. Where the iodine will come from? The iodine will be come from the normal diet. Yes, iodide, as iodide, it will be entered into the circulation. Usually, we used to have a iodized salt, right? Iodized in that 1,000 part of iodide, 1,000 part of salt, you may have a 1 single part of iodide that will be entering in your bloodstream. Once the iodine enter in your bloodstream, what happens? 20% will be flux inside to the follicular cell, and remaining 80% of iodide is excrete out through your kidney. Now, this iodide in an ionic form, that ionic form of iodide will not entering into the cell through your lipid layer, because the lipid layer will not allow the ionic form of any molecules or any one atom. It allows only lipid soluble substance. So the iodide can enter inside the cell with the help of some carrier protein. That carrier protein is called as sodium iodide co-transport mechanism. Okay, and here we need to know the two important things. The iodide are entering into the follicular cell against the concentration gradient. First, how this concentration of iodine is maximum inside your follicular cell. First, we have to know about that. And second important thing is the electrogenic activity of sodium potassium pump. This sodium potassium pump and iodine co-transport pump are present in the basal membrane. Okay, and it will not present in the apical site. It will be present only in the basal site. So the iodine that can be enter inside against the concentration gradient, number 1 point. And second point is your this one, the electrogenic activity. The electrogenic activity means it creates more negative potential inside the cell. That's why negative resting membrane potential. Am I audible, madam? Okay, Now the iodine entering inside with the help of sodium iodide co-transport mechanism against the concentration gradient. Now another one more point is iodine is a negative charge and inside the cell is a negative potential, that is negative resting membrane potential, that is created by your sodium potassium pump. So once the iodide entering inside the cell, yes, what happens? First it will activate inside your nucleus. Inside the nucleus there is a chromatin DNA strand, double strand. The specific gene is transcribed into an mRNA. That mRNA runs over a ribosome that produces a specific type of protein. That protein is called as thyroglobulin. Am I clear? These thyroglobulins are tyrosine rich protein. Around 140 tyrosine amino acid residues are present in your thyroglobulin. See, this is the thyroglobulin chain. Here, there are 140 tyrosine residues are present over here. Am I clear? So, this is a tyrosine rich protein. And this tyrosine have an affinity of getting the iodide, that is oxidation of iodide, that's to iodine. So it have an affinity of iodine into the form, in the circular form. See the ring form, it will be attached in the third and fifth ring of your tyrosine. Once this iodide is attached to the third ring, that is a third frame, it is called as monoiodotyrosine. Suppose if the two iodide, that will be two iodine that is attached to your tyrosine molecule, then it forms the diiodotyrosine. It is not compulsory that all the tyrosine in the thyroglobulin will not iodinization. Am I clear? This is not iodinization with all the tyrosine. In some tyrosine that will be attached with one iodide, in some other tyrosine that will be attached with the two iodide, that will form a monoiodide tyrosine and diiodotyrosine. Yes, next, this iodinization is occur and organification also will occur. Later, the coupling mechanism will occur. How this coupling mechanism is occurring and even iodinization will occur. See, listen here. There is a beautiful enzyme that will be present in the apical part, that is called as peroxidase. With the help of peroxidase, this peroxidase has some major function that can be used to iodinization, that makes the iodide into iodine. Okay, iodinization. Later, this iodine that can be attached to the tyrosine. Tyrosine have an affinity of iodine to hold the iodine with it. Yes. Next, what happens? Once it forms monoiodotyrosine and diiodotyrosine, the condensation reaction will occur. That is the fusing of monoiodotyrosine and diiodotyrosine with the help of your hydrogen peroxide. This peroxide will fuse both mono and diiodotyrosine. It will form a triiodotyrosine. In the same one, here you are having diiodotyrosine. The same way, if you are having two diiodotyrosine, what happens? These two diiodotyrosine will form tetraiodotyrosine. It is also called as thyroxine. Now, later, after the formation of MIT, DIT, and triiodotyrosine and tetraiodotyrosine, this is full with it. See, this thyroglobulin that is filled with the T3, T4, MIT, and DIT. It will also have an additional tyrosine molecule that is not attached with iodine. Okay. Later, after this synthesis reaction, what happens? Whenever there is a requirement in our body, that means thyroid hormone. If we need a thyroid hormone, after saving this, all the reaction, it will be stored inside the colloid. Inside the colloid, all the thyroglobulin that is attached with your iodine, that will be stored inside. So these are all the form of iodine that is attached to your thyroglobulin. Whenever there is a requirement of thyroid hormone that is stimulated, what happens? This thyroglobulin that can be enter into the follicle cell. This follicular cell, it will form a vesicle that can be easily enter inside the cell with the help of endocytosis. Now, inside the cell, we have a powerful hydrolytic enzyme that is an inactive form, that is called as lysosome. Now, this lysosome is full of hydrolytic enzyme that is called as lysozyme. Now it is attached to your this vesicle. Vesicle is filled with the thyroid hormones, that is thyroglobulin. Am I clear? Later, this will become active form, hydrolytic enzyme, lysozyme. Now it will cleave all the thyroglobulin. From here, your T3 and T4, it will be excrete out and it will be reach to your blood circulation. And the remaining part, dihydrotyrosine and monohydrotyrosine and some other tyrosine without iodide and some amino acid, it will be returned back to your colloid. Okay, later again the same mechanism in the presence of iodide actor. What happened? It will secrete from the nucleus. All the thyroglobulin will also form. Later it will be enter inside. After entering inside, what happens? The condensation reaction will occur. Whenever there is a requirement of thyroid hormone, again it will be excreted out through the cell and it will be reaches to your blood circulation. So now listen here. We'll summarize it. First one, follicular cells synthesize an enzyme and thyroglobulin for colloid. Okay, follicular cells, first it will be synthesized. From where it will be synthesized? From inside the nucleus, DNA. From the DNA as a specific gene that can be converted into mRNA. Later it will be converted as a tyrosine rich protein. Okay, thyroglobulin. Later, what happened? This iodide is co-transported into the cell with the sodium. That is co-transport mechanism that transport into the colloid, and enzymes that added iodine to thyroglobulin. What's that enzyme? That is called as peroxidase. That can be helped to add the iodide into the thyroglobulin to make T3 and T4. Depends on the attachment, monoiodotyrosine, diiodotyrosine. In condensation reaction, it will form triiodotyrosine and tetraiodotyrosine. Okay, now we'll see the difference between T3 and T4 thyroid hormone. These thyroid hormones, the T3 thyroid hormones are stronger and more active when compared with the T4. T4 is weaker and less active because this having one monoiodotyrosine is highly active that will be disturb your diiodotyrosine because of the free form. It will be ready to react, but in this case it is completely filled with a dihydrotyrosine to dihydrotyrosine. It is less active because it is more bound to the plasma protein, so it cannot be easily free from the plasma protein. But here it is less bound to the plasma protein, so it can be available in a free form and it can be easily excrete out. Even if there any need or is not required, it can be easily excrete out. So it will have a short half-life period, but it is highly bound. It cannot be easily removed from the plasma protein, so it will take a more time, long life period. And it constitutes, the T4 constitutes 90% of your thyroid gland secretory product. But in this case, the product is less amount from the gland. Now, some of the key points that you need to remember for the thyroid hormone. Thyroid hormones, the main thing is it will affect all the cells in the body. That's why we need to always have a thyroid with alpha, even a thyroid hormone. Even to generate it, we need a iodide. Okay, that iodide we will get from the iodized salt, even a dietary products. Okay, these thyroid hormones are highly lipo-like. Okay, lipophilic nature, so they can easily bind very quickly with the several plasma protein. The majority of circulating T3 and T4, that is transport with the help of thyroxine binding globulin. Only free form of portion of thyroid hormones that can have a target receptor that can easily exert on this effect. Thyroid hormones are slow onset and long duration of action. How come? How come it's very slow? Because suppose if there are any changes in the thyroid, what happened? It will start from the molecular level, from the DNA, then it transcript, and later it will be translate into the protein. From the nucleus, it will reaches to your colloid. Later, it will be reaches to your blood circulation after iodinization or organization. So it will take a long time to reach. Okay, that's why it take a long durations. And later, now we'll see about the functions of thyroid hormone. The most important function is stimulation of carbohydrate metabolism. it will increase the rate of glucose absorption in the GIT. In that way, it can increase the glucose uptake by the cells. So, if the glucose uptake increases, it can increase the glycolysis. So in that way, it can increases the energy, reaches to the needs. Whatever the needs required for us, it will be increase the glycolysis. If there is an absence of carbohydrate metabolism, what happen? It will be also increases your gluconeogenesis. Non-carbohydrate, it will also gives an energy to your body. Next, stimulation of your fat metabolism. This will increase lipid mobilization from fat tissue. So the mobilization of lipid that can decrease the fat that stores in our body. So it will be available in a free form, that is free fatty acids that will be increased in your bloodstream, and at the same time oxidation of your free fatty acids by the cell will also increases. And next is the effect of plasma on liver fats. It will be decrease the concentration of cholesterol and phospholipids and triglycerides in the plasma. Next, this thyroid hormone will also increase the basal metabolic rate or idling speed. That means it is the most important regulatory for body's rate for in case of oxygen consumption. Suppose if you want to do more work, you need to have a more oxygen consumption. In that way, all the cells, it should require more oxygen supply. With the help of thyroid hormone, it will also increase the rate and depth of respiration. By increasing the rate and depth of respiration, what happens? It will be increase the oxygen consumption. That means oxygen demand will be cleared. So whatever the oxygen consumption is required for the cell, that demand will be easily cleared with the help of increasing the depth and rate of your respiration. And at the same time, after the ending of the basal metabolic, it will increase the heat production. That's why it is also called as a calorinogenic effect. This will be increase the metabolic activity and results in increase the heat production. And it will also have an effect of cardiovascular system on even blood vessels. What happened? It will increase the blood flow by help of vasodilation. How come? See, for example, in the basal metabolic rate or even metabolic activity, it will produce the most metabolic wastages in your bloodstream. What happened? These accumulation of your wastages, metabolic wastages, it will try to increase or your vasodilate your blood vessels. By dilating your blood vessels, it will increase your blood flow. After increasing the blood flow, that will remove all the metabolic wastages from your bloodstream. Automatically, this will come back. The vasodilatation, now it will vasoconstrict. And it will also have an effect on the heart. It will increase the force and rate of contraction. Next, it will increase the GIT, gastric intestinal mobility. It will also have an effect of growth. It will stimulate the growth hormone secretion and production of your IGF. If there is an increased insulin like growth factor, it will inhibit your GH secretion, growth hormone secretion. If there is any requirement is not needed, it will also promotes the effect of GF, growth hormone, and IGF-1 on the synthesis of new structural protein on skeletal growth. It will also have an effect of bones and muscles, and it will also have an effect of nervous system. As a fetus and an infant, if there is a less amount of iodide, there is a no maturation of your fetal growth. That's why nowadays the fetal with the iodine defects, what happens? There is a mental retard like that condition is produced, and even as an adult, they will have a hormone insufficient that will have an effect, and the effect of your sexual functions. In men, hypothyroidism, that is a loss of sexual desires, and even hyperthyroidism, that is produce an impotency. In the same female also, hypothyroidism and effect of hyperthyroidism. Now we'll see about the thyroid hormone regulation of your thyroid hormone. There will be two types of regulation. One is a negative feedback mechanism. Another one is auto regulation of your thyroid gland. First one, negative feedback mechanism. What happened? This negative feedback mechanism will be occur with the help of your coordination of your hypothalamus and your anterior pituitary hormones, anterior pituitary glands. Now, if there is a requirement of thyroid hormone, what happens with the help of your anterior pituitary gland? It will stimulate your thyroid stimulating hormone. This thyroid stimulating hormone, it sends the information to your thyroid gland. It will stimulate your thyroid hormones, the thyroid hormone T3 and T4 that will reaches to your bloodstream. It will increase your metabolic rate and heat production. It will also enhance your growth and CNS development through your sympathetic activity. See, if there is an excess amount of your thyroid hormone in your bloodstream, what happens? It will send a negative feedback to your anterior pituitary. See, listen here. It will send a negative feedback. In that way, it will inhibit your thyroid stimulating hormone. In that way, it can reduce your thyroid hormone that can be secreted in your blood. Okay, next one, auto-regulation of your thyroid gland. Before that, now listen here, in case if we need a hormone, okay, thyroid hormone into your bloodstream, what happens? It will send the information with the help of thyroid stimulating hormone. Actually, what happens? It will involve in your follicular cells. Okay, it will increase your number of follicular cells, that is called as hyperplasia, and it will also increase the size of your follicular cells, that is called as hypertrophy. With the help of these two actions, it will increase your thyroglobulin condensation reaction and your organization reaction. In that way, it will increase your T3 and T4 in your bloodstream, and it will reach us to your bloodstream, and it will satisfy your thyroid hormone necessity. Okay, next one, if there is a decreasing, if there is an increasing thyroid hormone, what happens? It will inhibit your thyroid stimulating hormone. In that way, it can regulate your thyroid. Next one, auto regulation of your thyroid gland. What happens? Auto regulations, simple, it's about a food intake of your iodine. If there is a less amount of iodine, what happens in a food intake? The iodine that can be easily, see here, I will show in this case. Okay, now see, if there is a, in case of auto regulation, there is a food intake of iodine that will be reach into your follicular cells. That means influx of iodine into your follicular cell will also increase as in case of auto regulation. By increasing your iodine, that can reach to your colloid cell with the help of peroxidase enzyme. So in that way, it can increase your iodine level. So in that way, it can produce your thyroid hormone. Now it reaches to your blood. If there is excess amount of thyroid hormone in your bloodstream, what happens? This iodine influx will be very less. It will be stopped. Okay, in that way, it will stop your influx of ion, and it that production of your thyroid hormone will also reduce. In that way, it can be regulated in your bloodstream. Okay. And last one is about your CNS. Okay, that is the changes of your stress and your cold in infant. In that case, it will affect your CNS. That means mainly in the arcuate of your hypothalamus, that will increase your TRH. That is thyrotrophin releasing hormone. This will have an influence on anterior pituitary. In that way, it can regulate your thyroid hormone secretions. Okay. Up to this, synthesis secretion is over. Is there any doubt?
Students, if you have any doubts, kindly post it in the chat box.
Yes, madam, any doubts?
So it's thank you so much, sir, for accepting our invitation, and
Thank you, madam.
thanks for your cooperation. We had a nice lecture from you, and any queries? Okay, sir. There are no queries from the student side.
Okay, madam. And I would like to thank Dr. Muhilan sir and Dr. Jessica ma'am, and for giving me the opportunity to present the topic on thyroid hormone, physiology of thyroid hormone. Yeah, thank you, madam.
Thank you, sir. On behalf of Anatomy Department, we would like to honor you with a certificate. Just a minute, sir.
Thank you, madam.
Kindly accept the certificate and honor. Okay, sir. Thank you.
Thank you, madam.
Dear faculties and students, thanks for joining us in this session, and we thank you on behalf of Anatomy Department. I thank your cooperation, and kindly join in the afternoon session too at 2 p.m. with the link we have provided you. Thank you so much. We'll see you in the afternoon.